Than all of the rest of the world combined. And you are 65, this is 2017. Now you have passed already 70 million people with diabetes. And if you look at this is data just published last year, you see that of all of the Southeast countries, here you have India following some of the other countries have higher rate of diabetes. But the numbers will continue to increase, that's right. And here you have India with a rate of overweight and obesity that has significantly increased. And I have been coming to India during the last 6-8 years, almost every year. And I can see a difference in the shape of the population, especially in males with more prominent abdomen. So I think that you are not that obese as the United States or Mexico in America, but the rate of obesity is increasing, which is very alarming, that's right. And the progression or projection of the number of patients with diabetes has subestimated the reality. So if we think there are going to be 450 million, who knows what it's going to be in the year 2030, 2045. So how much we're going to increase? Of all of the countries around the world, look at numbers here in Southeast Asia. It's 3 times more. It's going to multiply the number of diabetes that we're going to have in the United States. 4 times more what is going to happen in Europe. So I think that everybody sitting in this room should be very aware of these numbers and the projections and try to do something, and those who have contact with the government to try to modify or do governmental or federal intervention to prevent diabetes. Let me stop here and move to the United States. And here you have the trends of diabetes diagnosis that is reported for the CDC, the Center for Disease Control in Atlanta. And what you have in here is the rate of obesity, that's right. And obesity is the driving reason why we have so much diabetes. In the year 1990, so this is just 20 years ago, or 30 years ago, very few states had a prevalence of obesity, of diabetes, that it was more than 5, 7, 8%. Look what it is now. It's just amazing, the number of patients with diabetes. And here I live here in Georgia. Atlanta is located here. And here we have, for us, it's the same like you, we have what is called the diabetes belt, where the prevalence is about 12% compared to the rest of the country. Why is that? Likely because of the higher number of African Americans that we have. In Georgia, 37% of our patients are African Americans, are Black, and Black has more diabetes than whites. And the other thing is the high rate of obesity. Here you have what it was in the 1990s. Very few states has a prevalence of diabetes greater than 19-20%. Look what we have right now with some states that 1 out of 3 patients have, or 1 out of 3 individuals are obese, and obese diagnosed with a BMI greater than 30. And if you look at the rate of obesity with BMI greater than 30 among African American females is 40%. That's why the rate of obesity is so high, that's right. So when you talk about diabetes, you have to think about pre-diabetes. And we have 30 million people with diabetes in the United States. We have 80 million people, or 86 million people with pre-diabetes, defining pre-diabetes as a state who have high risk of progressing to diabetes. So what can we do to prevent diabetes? That's right. First, we have to identify the population. Second, we have to establish lifestyle intervention. We can treat it or use medication for this, and we also have metabolic surgery. So What is prediabetes? I don't have to tell this audience. But remember that we have impaired glucose tolerance and impaired fasting glucose. So impaired glucose tolerance is used when you do the oral glucose tolerance test, and it's very seldom done. But this is more effective, and they're 2 times more likely to have impaired glucose tolerance than impaired fasting glucose. Impaired fasting glucose is the blood sugar between 100 and 125. You can also do impaired glucose tolerance with the oral glucose tolerance test between 140 to 190, and the hemoglobin A1C that can be used. So impaired glucose tolerance is 50%, impaired fasting glucose is 23%, and combined impaired glucose tolerance and impaired fasting is 25%. So 3 out of 4 patients with prediabetes have a postprandial glucose excursion of hyperglycemia after meals. So there are several organizations like the American College of Endocrinology, IDF, ADA, who has highlighted who should be tested. So I think that we all agree that diabetes and prediabetes is the disease of the adult. There are many children with prediabetes and diabetes, but the increase you're going to see is after the age of 45. So if you are over the age of 45 and your BMI is greater than 25, or here for Southeast Asia, greater than 23, that is most of you, you are at risk of diabetes or prediabetes. So what you do is going to do a fasting glucose, and you do a hemoglobin A1C. So what is best? A fasting blood glucose is better than hemoglobin A1C, but those 2 together are better than either one by itself. So in the United States, we're doing a lot of that. Our primary care physicians are doing a lot of hemoglobin A1C. But there is a lot of deficiencies with A1C, especially in African American patients that tend to read higher. We want them to do a fasting blood glucose because you miss the diagnosis of prediabetes in about 1/3 if you use just hemoglobin A1C. So who should be tested? Those who are physically inactive. I don't know what is physically active, but maybe if you do 180 minutes or 3 hours a week, you're an active person. Less than that, you're inactive anyway. So anybody who has a family history of diabetes, anybody in this room who is not Caucasian, except George Grunberger, we all are at risk of having diabetes. So anybody of us who has more than age 45 should be tested for prediabetes. Hypertension. Hypertension is one of the highest risk factors for diabetes and prediabetes, same as hyperlipidemia or cardiovascular disease. So let's review intervention studies, and let's start with lifestyle intervention studies. There are a large number of studies that have been proven the intervention. The 3 most commonly cited in the literature are the Diabetes Prevention Program in the United States, the Finnish studies from Finland, and the DAQUIN study from China. And what you see is that the number of people go from 500 to 3,000. Most of them were overweight, except of course China or in Asia, where the people are less heavier. And the intervention periods go from 3 years to 6 years. And the relative risk reduction. So for the diabetes prevention program, doing exercise, and I will discuss more in details, and good diet, losing about 5% of body weight, prevented diabetes in about 58%. Similar guidelines from Finland, 39%. In the DAQUIN studies, the relative risk reduction was 51%. And if you say, well, how many people need to be on intervention to prevent diabetes? And this is included in the number needed to treat to prevent 1 case of diabetes. You see they're highly effective. You just need to put 20 people and you prevent 1 case of diabetes and its complications. So the Diabetes Prevention Program is the largest studies on prevention. It included about over 3,000 patients who had pre-diabetes, and they were intervened to undergo lifestyle intervention based on diet and exercise. Weight reduction, about 5 to 7% was the primary goal. with exercise about 150 minutes a week. And it was compared to a group of metformin and to a group of placebo. And what they reported, looking here to your right, is that the metformin reduced the risk of diabetes by about 30%, and lifestyle intervention was better than metformin with a reduction of 59%. So 2/3 of the cases were reduced by lifestyle intervention, 58, a little better with metformin compared to placebo. And both metformin and intervention were, of course, significantly reduced from no intervention at all. So who will benefit? And this is something that we should keep in mind, is that elderly people, or older people, not elderly, older people over the age of 60, you will see that they were the one who benefited the most with lifestyle intervention. And I want you to look at this group of, so the younger people, the difference between metformin and lifestyle intervention was better than nothing, but there was no significant difference. So if you have somebody who is young, who is overweight, who is at risk between the age of 25 to 40, perhaps it's some group of people that you may think of using pharmacological intervention to prevent diabetes. The Finnish study is a large study, but much less. It's 500 patients who have been followed for a long period of time. Again, they have pre-diabetes, and they went from lifestyle intervention for 3.2 years. And what they reported, similar to the DPP, a significant reduction of 58%. So 58% with just lifestyle intervention. So diet and exercise was significantly better than no control. They didn't use pharmacological intervention in these studies. And this is the Duck Queen or the Chinese studies that also shows that lifestyle intervention reduced diabetes by 65%. So, and this intervention was just not just during the intervention period, but it has a memory effect, and after 20 years, they still see a difference on the rate of diabetes. So lifestyle intervention is effective. So how much weight do I need to lose to prevent diabetes? So the goal of this study was 5 to 7%. 7% is the ideal, 5% is what they achieve. But you don't need to lose 10%, 5%. Even losing 2 kilograms or 2% of your body, you will reduce the rate of diabetes significantly. And of course, if you go from 2 to 5 and 5 to 10, the rate of diabetes is even greater. So if you lose 7%, so somebody like me, that I'm about 80 kilos, 5% would be 4. If I lose 4 to 6 kilos, I will have a reduction of diabetes greater than 50%. But if I only lose 2 kilos, so 5 pounds, my rate of diabetes is significantly increased. So it doesn't matter how much weight you lose, you're going to do it. So what is the problem? In these studies, to translation to the community. And if you look at the number, how intensive is the CDC and the National Prevention Program, it's difficult to achieve. We have it at our university. Right now, we have over 100 people every 3 months enrolled in these studies. And what we see is a minimum of 16 core visits over a period of 6 months. So we ask the individuals to come every week to see us for 6 months, which is highly demanded, almost impossible. Imagine that every Friday you have to go from 12 to 1, like going to church, for 1 hour to receive intervention. And that has been the main problem that we see with adherence to this therapy. People complain to us that they just can't leave work every week for 1 hour. And after 6 months, they come for 1 month, every monthly visits. So that's the problem, that in non-study condition, the success rate is not that much. About 30%, so 1 in 3 complete the programs. 1 in 3 achieve significant weight loss. So the 59% reduction seen in the diabetes prevention program studies had not been reproduced in the National Diabetes Prevention Program. So lifestyle intervention is the best. 35% achieve 5% of body weight. And that's something that you have to keep in mind when you're doing lifestyle intervention. Only 1 out of 3 will achieve goals, and even less than that will achieve the exercise they need to do. So with the limitation that we have with lifestyle intervention, can we use pharmacological therapy? So there are several studies that has been shown and reported with metformin, acarbose, DPP-4, thiazolidinediones, and now GLP-1s. So let's review each one of them. Metformin was the DPP. There is the Indian studies, and let me just move to them. Metformin. If I have a patient with prediabetes and I give metformin 500 or 850 milligrams twice a day, you're going to see a reduction of prediabetes progressing to diabetes about 31%. The younger, better than the older. But you have 1 out of 3 prevention. This is the Indian prevention studies. I'm sure most of you will know these studies. They compare a control group, lifestyle intervention, metformin group alone, or lifestyle intervention plus metformin, hoping that lifestyle intervention and metformin was better than the control group. And this is what it was reported in the Indian diabetes prevention program. If you use lifestyle intervention, you achieve 29% reduction of going from pre-diabetes to diabetes. So a little less than the American study. If you treat the patient and just give 1 little tablet or 2 tablets a day of metformin, you achieve similar results. And if you do lifestyle intervention plus metformin, there was no difference. So when you look at this data, you say, gee, should I do lifestyles? Sure you do, because you're not only to reduce body weight, metformin has minor effects on body weight, you improve hepatic glucose insulin sensitivity, so it's very effective. But the combination is what is preferred for most people. So metformin is good. There are other studies that is called Stop NIDDM using acarbose. And here in India, you use acarbose. In Japan, they use it even more, in China and Spain. And acarbose, as you know, blocks the glucose absorption after meals, was also shown to be effective in preventing diabetes. Perhaps of all of the medications for diabetes, the one who is most effective in preventing diabetes are the thiazolidinediones. And there are 2 studies. One is called the DREAM studies, and the other is called the ACT-NOW studies. The DREAM study was with rosiglitazone, that they saw a 60% reduction. The ACT-NOW studies with pioglitazone, 1 tablet a day, decreased the rate of diabetes by almost 80%. Even that they have increased body weight, there was prevention of type 2 diabetes. More recently, we have the GLP-1s. So the GLP-1 in the 3 milligram dose, and this is liraglutide 3 milligrams, this is for weight loss. They saw a significant amount of weight loss, and here to your right is the progression from pre-diabetes going to diabetes, and you see that the number of patients with pre-diabetes was significantly decreased. The rate of this is significantly much better than what you would see with most of the other medications. That's right. The other alternative that we have to prevent diabetes is produce weight loss. It doesn't matter how you lose the weight. Just go ahead and do it, that's right. Or with diet and exercise, with metformin, with the other medications. But there are several of these studies for weight loss that were discussed by Dr. Garvey yesterday. You have significant reduction. If you lose weight, you lose the ability, you decrease the rate of going from pre-diabetes to diabetes. And not only medication, but also bariatric surgery. Now we know that bariatric surgery is more effective than medication for weight loss. We know that this metabolic surgery prevents diabetes or the need for medications. And it also has shown to reduce the risk of progression from prediabetes to diabetes. So what we need to do as a society? So we talk about diabetes, 70 plus million people in India, 30 million in America, 450 million around the world. In the United States, every 21 seconds, there is a newly diagnosed diabetes. 70% of the patients who come to primary care who are obese, the doctors do not mention the word weight. 70%, we don't address weight. And what we need to do is to discuss with our patients that lifestyle intervention is the best way to lose weight. Now, our patients know that they have to eat well to do weight loss. So what is the problem with this? I mean, I think that we all know that we should stop eating or should eat less or should eat better. But I think that there is a disconnect, and we as society have to work harder in trying to do something, not just giving medicine when you have diabetes, but also prevent diabetes. And this perhaps is the most important thing that I've read during the last couple of years, is that if you lose weight, even if you fail and the patient goes to diabetes, and this is what you have, remission of diabetes, if you lose weight, and you have here in these studies, if you lose 5%, you stop using medication, your your glucose will normalize. Look what happened if you already have diabetes and you lose 5 to 10%. Somebody like me, 4 to 10 kilos, 4 to 8 kilos, 50% of people will stop using medications. And if you happen to lose more than 15% of your body weight, so 10 to 15 kilos, the utilization of medication for diabetes is 86%. If you apply this to a pre-diabetes state, the chances that you will progress to diabetes will be significantly less or almost non-existent. So we need to accept the fact that lifestyle intervention is the way to go. I am convinced that the use of medication has to be there early on. And the question is, which one of the medicine? That's right. Well, metformin is free, it's very little, it's not expensive at all. The other medications like thiazolidinediones could be a good offer, a good choice. So if I have a patient that metformin cannot be used, maybe thiazolidinedione should be very, very good. The problem is that thiazolidinedione of pioglitazone is associated with weight gain. And 80% of patients with prediabetes are overweight or obese. But using lower dose of thiazolidinedione, like 7.5 or 15 milligrams, is likely to prevent the progression of prediabetes to diabetes. The Center for Disease Control in the United States is pushing for lifestyle intervention. It's good, but not enough in most people. And I think that metformin, as we published in the standard of care this year and last year, should be considered early on for those patients that are progressing from prediabetes with higher levels of hyperglycemia, especially in those who have younger, less than age 60, and everybody who has a BMI over the age 35, those women with gestational diabetes. 50% of women who have gestational diabetes will become diabetic within 5 years. When are you going to start medication? When are you going to start intervening? Well, do a fasting blood glucose, do a hemoglobin A1C, and try to decide if they have prediabetes. Which is the best test to diagnose diabetes or prediabetes is fasting blood glucose together with hemoglobin A1C. And if you have both, it's better than either one by itself. So I think that what we have to have in mind is that lifestyle intervention is good. Medication should be used early on, and the selection of the medication depends on access. And where I think that metformin, thiazolidinedione should be considered early on in these patients. So I appreciate your attention.